just like to say hi to everyone, and it looks like a really great turnout. So that's really nice. So as Rob said, I've been working in on and off in kind of salivary gland cancer for the last 4 or 5 years, and are now kind of doing it full time for at least for next year. And I'm really enjoying it so far. So I'd first just like to say, if my slides will move on, a huge thank you to all of you for engaging in the research, for being willing to travel up to Manchester to see us, sign our long consent forms and have these conversations. So without you guys, it would be really difficult to get this kind of data. And so I'd just like to say thank you for that. So I guess, first of all, what is molecular profiling? Now, molecular profiling is where we look for specific changes within an individual's tumour. So we can do this under the microscope and look for different characteristics of just how it appears. We can put some stains on it, some dyes, and we can see if that makes it look any different. We can, put some probes on which make it glow up in certain ways, and that helps us see what's changed in the DNA. But we can also look directly at the DNA, and we can sequence the DNA to look for specific changes within it and see how those changes might affect the proteins, and how those proteins then might affect the cancer. So what we've done is we started off kind of a few years ago now, is we looked primarily at 24 genes. So a small-ish kind of targeted panel of the 24 most commonly changed genes within cancer. And the aim was to see, can we pick up anything? Is there anything there which is a signal which might help us, choose a treatment, or just give us a little bit more information about adenoid cystic carcinoma or other salivary gland cancers as well. After that, we then moved up a little bit. So we started looking at kind of 350 to 500 cancer-associated genes. And that's the process, the stage that we're kind of at now, and we're looking at that data at the moment. And then the next step, which we're really excited about, which we're starting to look at getting the data for in the coming year, is looking at all of the genes within the cancer. And that's going to be really exciting and provide quite a lot of new information, which we're really excited about. So the process that we've kind of gone through is to look at the targets. So first, we do the sequencing, and we see, are there any changes there? Are there any genes that create proteins that mean we can look at if a drug would stop them, if a drug would help? And if we find a target, if we find one of these mutations, then we look at the evidence behind the drug. Is the drug good? Does the drug work in that target? Does it work in other cancer types which also have those changes? And if there is a drug which does that, is there a trial for it? Can we get you recruited into a trial so that you get the support you need during the treatment? Or is this a drug which has actually been around for a while, and we can actually get funding for it and use it kind of on a compassionate use basis? So that's the process and the kind of the steps that we take. So now just going to go into a little bit more detail on the identifying the targets and how that works, and then look at how we decide on the evidence, and then look at the trials that are available to us currently in the UK, and then also the next steps in terms of where we're going and what trials might be opening up in the future. But at any point, if anything's not particularly clear, please raise your hand on Zoom or notify anyone in the room, and I can stop and kind of explain in more detail. So it's a busy slide. It's a really busy slide, and I'm not sure if you'll all be able to see it in the room particularly well. What we've got here is the results of quite a lot of work. So this is the results of around the first 200 patients, 200 individuals with salivary gland cancer, who we put their tumour through this 24 gene panel. And these are what we've identified. These are the potential targets which might help guide treatment, but also might help give us an understanding of how the cancer works and how adenoid cystic carcinoma and these other salivary gland cancer works. And if you can see my mouse here, you can see that there's these bars along the top. Now, each column represents an individual's sample or part of their tumour. And going across ways, we can see the genes that we're looking at. So in the top left, we've got TP53, and we can see that within adenoid cystic, it's mutated or changed in about 10% of individuals. And then we move down in terms of how frequently we pick them up. And what we can see here is that within adenoid cystic, we're only picking up, using this 24 gene panel approach, changes in about 16% of tumours. If we look in other tumour types of salivary glands, so at the bottom here, we can see salivary duct carcinoma, which is in this box. In this one, we're picking up changes in about 80 to 90% of samples. And then furthermore, we've got adenocarcinoma, and again, it's about 40%, myoepithelial is about 50%, expleomorphic carcinoma is about 50%, and acinic cells about 25%. And so going back to the kind of the process, these are the targets that we now have to play with. These are what we can say, okay, we have got, so if we take this first column here, these would be the results we would get. We would get that there is a change in TP53 and there is a change in EGFR. Now we say, okay, what does EGFR do? And are there drugs which can target EGFR? Can we say, okay, this tumor might be dependent on this change? Is this the change which is pushing the cells to divide? And by targeting it, can we stop it? So that's the premise. And if we move on to the next slide, it's again very busy, but I'll talk you through it. And again, let me know if anything needs to be kind of explained in more detail. But on the left column here, we have the genes or a selection of the genes within that 24 gene panel. So these are some of the results that we might get. In this next column, we have this SCAT score. And this is a score that is based on the European Society of Medical Oncology guidelines for how do we identify potential targets which will help with improving response to the drug. So within it's a 1 to 5 scale, and 1 means that this is a target that has a drug which has passed all regulations in big phase 3 trials and is shown to improve the overall survival of individuals with that change. Then 2 is that it's shown to have a clinical benefit, but it's not yet known, or it's not yet reached its endpoint of whether it changes the overall survival. 3, which is the category that the majority of our changes fall into, are that this has shown benefit in a different tumor type. So this drug or a drug combination with this certain change means that patients with, say, lung cancer or prostate cancer have been shown to benefit. And the rationale is thinking, okay, if patients with prostate cancer have benefited, will patients with adenoid cystic carcinoma benefit? And can we then access the drug, or can we go on to a trial, and can we see if that is, and can we test that, and can we see if that will help? 4 means that it's not been shown to have any clinical benefit yet, but it's shown that in early research in studies within cells and in the lab, there is a rationale, a scientific rationale about why this change within a protein might be responsive to a certain drug or a certain type of drugs. So we rank for the changes that we get based on this scale. And then we say, okay, is there a trial available in the UK which is looking at this change with a drug which has a good evidence level? And you can see on this middle column, this is the results we have. So these are the trials which were open over the last 3 to 4 years that have recruited patients of any tumor type, which would therefore include adenoid cystic carcinoma or other salivary gland cancers, and for drugs that they would be trialed with. And so if we go back, we can see that something like this PIK3CA mutation in this individual here, and we take it down to here, we could try an AKT1 inhibitor, or we could try a PI3 kinase inhibitor as part of these trials. Now, one of the limitations to this is that these are generally quite small trials, recruiting individuals from about 20 to 50 patients, and they can be based all over the UK because, as it is quite clear, you know, this is a nationwide event and a nationwide kind of approach that we're taking. So it doesn't always match up with the individual being in the location that the trial is at, or that the individual is at a point where that trial would be useful for them. In a lot of cases with adenoid cystic carcinoma, with the slow change, we don't necessarily want to go in with a trial if your symptoms are okay. We don't want to give a drug which we don't know how that's going to affect you necessarily, and so it's a balance. So, but what we did see is that, you know, we're only picking up about in adenoid cystic, about 17% of individuals have a change, and there's only trials available for those changes in about 10%. So we thought, okay, how can we improve that? How can we get a higher pickup rate? So we took samples from patients who had no changes in their tumor, and we put it through this larger panel, this 350 to 500 gene panel. And we said, okay, are we picking up anything else? Is there more that we could act on? And so this is the results of those. And you can see there's again, it's similar. So we have the genes down the left-hand side, and we have the percentage of individuals who have that change. And again, each individual is represented in a column. And so we said, okay, now we've got more to play with, and we can see here that, you know, there's higher rates here. We're seeing changes in Notch in 13%, and some of you might be aware of the accuracy study which went on within adenoid cystic carcinoma, looking at a Notch inhibitor. So here we've got 3 changes or 4 changes in Notch. So we found something here which could be useful. You've got this one, PIK3R1, which is similar to PIK3CA. So again, could this be targeted with these AKT1 inhibitors? So we've thrown the net wider to see if we can catch kind of more of these targets. But the issue with this is, as we throw the net wider, we move away from the other big groups, the prostate, the lung, and things who've got their targets in EGFR and things like that. And what we find is that although we're picking up these targets, and that there is evidence based on the on preclinical trials and preclinical research, but the trials aren't open in the UK for us to match at this stage. And so as we've thrown the net wider, we pick up more, but whether we can get patients onto trials through this approach, I think is going to increase as more and more trials are opening up, and we'll come on to that, I think, on the next slide. Does that all kind of make sense so far?
Yeah.
Perfect. Okay. So what is next for our approach? So the first one, as I alluded to, is we're getting targets now. We're picking things up, but can we get patients onto trials if there are no trials? But there are more trials opening up now within the targeted setting than ever before. And we're also seeing basket trials come to the UK. So a basket trial is where you take kind of 10 different changes, 10 different mutations in different genes, and you match that with 10 different drugs which might target that. And you say, okay, any individual with this change can come on this trial. And that means that you're not looking at just lung patients, you're not just looking at prostate patients, you're looking at patients who have a change in ALK or BRAF or one of these, one of these changes that we've picked up. And so opening hopefully in the next year is going to be the Tapestry trial. So this is a large basket trial, and it's looking at about kind of 8 or 9 different variants, different changes. But I've highlighted here the ones which could affect, from what we've seen, the adenoid cystic population. So we know we've picked up changes in AKT1. We know we've picked up changes in BRAF. We've picked up changes in HER2 within other types of salivary gland cancer. And we've picked up changes in PIK3CA. So that's how the scene is changing within the trials. But then from our side of things, okay, we're thinking, let's throw that net wider as well. Let's see if we can see more changes. Let's see if we can understand this tumor to the best of our abilities. And as I alluded to earlier, we're now starting to look not just at 24 genes or 300 or 500 genes. We now want to look at all of the genes within that cancer. And hopefully that will, the main aim is to understand the cancer, but also in the future, see, can we use this to change treatment? Can we use this to guide trial options? We're also looking at immune profiling, trying to understand how the immune system plays a role within adenoid cystic carcinoma. We know that it doesn't respond particularly well to immunotherapy, but why not? And is there a way to change that in the future? Is there a way to intervene there? And then there's also more data coming out, as I alluded to before, in other tumor types. So we're seeing more and more trials within lung, we're seeing more and more trials within prostate of targeted therapies, targeting specific changes. And that data is useful to us because we can look at that data and we say, okay, it's worked in there. Can it work within adenoid cystic? And if it works enough in another tumor, can we apply for funding to say, okay, can we give it a go? And then what will be talked about quite a lot later on by Professor Salo is going to be MIB. So we know that adenoid cystic carcinoma is driven by MIB in the majority of cases. And so we should be looking more focused on the changes that we know are already there within every patient with adenoid cystic carcinoma and how we can then kind of, tailor our approach to looking at MIB and its other targets, which will be the focus of the talk this afternoon. So I'd just like to say again a big thank you and a big thank you for having me here. And if there's any questions at all, then please ask.